Hello, and welcome to CHD Wise, an education series for patients and families. My name is Rebecca Acosta, and I am the Education Director here at Conquering CHD. Tonight, I'll be joined by our ACHD Director, Jennifer Weiner, who is also living with CHD. She will be moderating the live Q&A portion of tonight's event. On this episode, we will be discussing COVID-19 vaccines and CHD. As a housekeeping note, audience members are muted and should send their questions for the experts via the Q&A feature on your Zoom dashboard menu. For most of you, this will be at the bottom of your screen. This episode is being recorded and will be available for viewing on our website in the coming days at conqueringchd.org. Tonight, I'm happy to welcome several experts in their fields. Dr. Satoshi Kamidani of Emory University is a specialist in infectious diseases. Dr. Roni Jacobsen of University of Colorado and Colorado Children's Hospital is an adult congenital cardiologist. Dr. Matt Oster is a pediatric cardiologist from Children's Healthcare of Atlanta. Dr. Kumar Subramanyan is a cardiac surgeon from Children's Hospital Los Angeles and also serves as the current chair of our scientific advisory committee. Dr. Nicolas Madsen is a pediatric cardiologist from Cincinnati Children's Hospital. In order to share the most information possible in such a short time, each physician will answer some questions that were submitted by our audience prior to today's event. Since the experts are not your personal physicians, they will not be able to answer questions regarding your specific anatomy or your specific treatment. However, patients and family members are encouraged to take the information you learn this evening directly to your care team for specific guidance. I'll now invite our physician panelists to turn on their cameras. Good evening. I'm gonna make sure we've got this laid out for everybody watching. Dr. Subramanyan, I love the tie. All right, now that we've got everybody turned on and logged in, we'll get started with the questions that were submitted by the community. So last week we asked in one of our heart polls that goes out every week on social media, what you all wanted to know about COVID-19 vaccines and CHD. And oh my gosh, you responded. We received over 100 comments on Instagram and nearly 300 comments on Facebook. And despite the large response, I think you'll all not be shocked that most questions fell into a few specific categories. So the first question I'm going to pose is to Dr. Kamidani, and the patient emailed and said, what do I need to know about vaccines in general? I have not had any vaccines as an adult other than my annual flu shot, and my parents handled all of my childhood vaccines. So if you could address those questions and then maybe also give us kind of like a vaccine 101 science lesson with your expertise.
Sure. Hi, my name is Satoshi Kamidani at Emory University. And I need to just kind of mention that I'm co-investigators of Emory vaccine and treatment evaluation unit, and then involved in the COVID vaccine trials from the phase 1 and through the 3. So, but I don't have any financial conflict to disclose for today's discussion. So for that question, so to understand the how vaccine works, it probably helps to first look at how the natural immune system in the body fights the infection. So when germs, as like a bacteria or virus, invade the body first, then they start to attack, and then they multiply, and then cause issues and infection. So this invasion triggers the immune response, and the immune cells called like a white cells fight off these germs. And then once they are able to get rid of these germs, then they try to remember the shape of the germs in case they attack again. So then later when the same exact germ try to invade again, but then the immune system against that germ is much stronger and then more efficient to fight off these germs. So basically what vaccine does is to develop the immunities by imitating the infections without causing the true infection. So for example, the live virus vaccines contains the versions of the living virus that has been weakened so that they can't cause a serious disease. So because that's live, but not like a natural virus and then weakened, these are the closest things to the natural infection. So they're really good teachers for the immune system. So they can learn how to fight off these germs. They can learn what the shape looks like. So then they generate a good response, the immune response. So the same process as the natural infections, the body tries to remember the shape of the virus or germs, and then to be prepared for the next actual infection. So that's the general concept of the vaccines.
Thank you so much for that. I think many of us didn't get that science lesson in school. So I do have a follow-up question specific to the COVID-19 vaccines and how they've been created and tested and trials in humans. If you could give us some background on how that process usually works, and then maybe if you are comfortable in sharing any differences between the two available vaccines. And if a patient who has already had COVID-19, should they still get a vaccine?
Okay, right. So those are really great questions. So first of all, there are different types of the vaccine platforms, like as I mentioned, like live vaccines, killed vaccines, and vector vaccines. So a lot of vaccine platforms exist. But the beauty of this, the messenger RNA vaccines, so mRNA vaccines, is they don't use like a live vaccines or killed vaccines, and they don't contain like antibiotics or even adjuvant, so they don't have that in the vaccine. So the Pfizer, BioNTech, as well as the Moderna vaccine created this the novel technology based vaccine. So I like to kind of focus on this kind of vaccines among these a lot of like platforms. So the mRNA stands for the messenger RNA, which is actually so-called like the kind of blueprint for the making the vaccine. So what they do is to provide the instructions on how to make the protein to generate a good immune response. So and then that mRNA gets in the lipid bubble called the lipid nanoparticle. So this lipid layer helps gain the access into the human cells. Then once it's in the human cells, the mRNA gives the instructions to the cells on how to make the proteins that we need. It's called like a spike protein. So the COVID virus caused issues by using the spike protein. So they try to attach to the human cell by this spike protein. So spike proteins attach to the human cells and then get into the human cells. So we want to prevent that by blocking the spike proteins using the antibody. So the mRNA vaccine produces the spike protein in the cells, and then the cells express the spike protein, and then the immune system says, it's interesting, it's not like something ours, and then it must be germ or like an enemy. Then the immune system in our body try to generate the antibody against this spike protein to block or destroy this spike protein. Then when the people get the COVID virus, the immune system knows how to make the antibody against the spike protein to protect the infections from the COVID. So that's the kind of concept of the mRNA vaccines. Then how we test these vaccines is that it's a rigorous process to ensure that safety and then efficacy. So what we do is we test these vaccines in the animals, and then we do the human trials from like a phase 1, 2, and 3. So all vaccine trials are having the hard stop criteria. What that means is that once we see some like safety signals, like any serious adverse events, then we stopped entire trials. Then check that the cases of the side reactions. Then once we ensure that the vaccines are safe, and then that signal is not like the causal relationship, then we restart the vaccine trials again. So I know that a lot of people are concerned about sometimes they say like the vaccine was made like very rapidly, but in fact, we had a very strict criteria for these kind of stopping trials. And then we carefully examined all volunteers and ensure that everyone is safe. So it's a lot of process occurred during this vaccine development. Then the FDA reviewed all data very carefully, and the Pfizer's and the Moderna vaccines were approved for the emergency use authorization, and now it's available for like the people above 16-year-old or older for the Pfizer vaccines, and 18-year-old or older for the Moderna vaccine. And then that's kind of process of the vaccine trials. And does that answer your question, Rebecca?
Yes, it does. And that patient, when they asked those questions, also wanted a brief explanation, as much as you can, on why a patient who has already had COVID-19 should still get the vaccine.
Right. So that's really great questions, and then actually the million-dollar questions right now. So so a couple of reasons. So the one is we don't know how long the immune lasts after the natural infection. So there are a couple of studies that check the durability of the antibody productions after the natural infection. However, again, we don't know how long it lasts. So, and then the other point is that the Moderna studies and the Pfizer studies showed that they actually had a couple of people who actually had a COVID in the past based upon the serology test. So they showed, especially the Moderna study shows that there is no significant differences in terms of the safety between the people who got the COVID in the past versus the people who didn't. So they, based on that data, the CDC recommends for now that the people even who got the COVID in the past require like a regular series of COVID vaccines. But that being said, that one of the caveats of this trial is that we exclude the people who knows they got the COVID infection in the past. So we try to exclude these people in the phase 3 trials. But people who had the asymptomatic symptoms, like asymptomatic infection, they don't know whether they got the COVID in the past, right? And then we check the serology during the studies, and then they found out, oh, this volunteers has a COVID in the past. So these data comes from probably the volunteers who had asymptomatic COVID in the past. So what that means is that we don't know much about the safety data in people who had a severe COVID or symptomatic COVID. That might be different from the people who had asymptomatic COVID. So from that standpoint, if we see more people, I heard that anecdotally that the people who had like a severe COVID or symptomatic COVID have more reactions following the COVID vaccine. So if that's the case, and then we see more of these cases, then the CDC may change their recommendations based upon the future data. But for now, again, based upon this phase 3 safety data, and also we don't know the durations of immune protections. That's why CDC recommends like a regular series for these people.
Wonderful, thank you so much. These next group of questions are going to go to Dr. Madsen and Dr. Oster as our pediatric cardiologist on the panel tonight. We know that the vaccines that are currently available are for teens 16 and up or adults 18 and up. What can you share about the future of pediatric COVID-19 vaccine trials with us?
Yeah, I can say, yeah, sure. So yeah, kind of looking into this, and Satoshi, you can jump in because I know you are involved with a lot of the trials. So yes, you're right. So the vaccines, the Pfizer one, I believe, is approved at 16 and Moderna at 18, and that's based on who they were tested in those trials. Just like Satoshi was saying, we can't, give any sort of approvals for use in people that it hasn't been tested in yet. So, younger kids, can they and should they be tested? And the answer is absolutely. And there are trials ongoing to do that, I believe down to age 12 for right now, if I'm not mistaken. So those are ongoing, and that's going to take a little bit of time. I know they were having some trouble, at least the Moderna ones, in recruiting patients early on. But I think hopefully they're making efforts to get more children into it. So again, being studied down to age 12 for right now to start that approval. And then eventually, it may get into younger and younger age populations. So we still don't know much about how this vaccine will work in kids, but I'm glad to see that the process is doing what it should be doing. I know people were worried about a lot of the speed and were corners cut, and I definitely had those concerns early on. But I think things were done the right way, and the companies in the FDA try to stay by the book despite a lot of the pressure put on them by many outside forces. And I from what I'm seeing and how they're trying to test kids, I see the same process rolling out. So hopefully we'll get some good results in the coming months.
Do you have anything to add, Dr. Madsen?
Yeah, just agree with all of that. If for those that are interested, you do have the opportunity to seek out the opportunity to enroll your children in these various trials. There's obviously some careful screening. It's unclear at this time to what degree they would exclude anyone with a pre-existing condition, and if they would differentiate by complexity of the pre-existing condition. So that has not. I have not been able to discover the answer to that question, but certainly there is the ability to search out the Moderna adolescent vaccine trial and to see if there's any local representation or nearby representation that you could ask those questions of. I think it, as Matt points out, is extremely important for us to understand the reactions and the benefit of the vaccine for adolescents. Certainly it's important to understand the safety profile. I think it's a little bit hard to understand why a vaccine would be safe and effective in a 17-year-old and not a 12-year-old. Biologically, it's hard to appreciate the difference. But I think the other major reason to study it is we need to appreciate the effectiveness of the drug. So not so much is it safe or not, but does it have the same benefit, so that those who pursue vaccines in the future understand the ramifications and the potential for benefit overall.
Thank you for that. And Dr. Madsen, you answered my next question. A lot of parents of children with CHD reached out and asked if patients that are stable with CHD would be allowed to participate in any potential pediatric trials. And then the other question we received the most about pediatric population is if pediatric CHD patients will be considered in the high priority category to receive vaccines. before the
Yeah, I
general
think
pediatric population?
we're learning more about the high prioritization category, certainly as it relates to adults, and I'm sure Roni will be talking a little bit about this. They are listing congenital, in some states, severe congenital as their phase 1B or whatever the state may call it. The definition of severe is not precisely given, and so I think there's room for interpretation there. But I think obviously I'll let Roni talk about the adult aspects of that. But I think whatever is put through for the adult patients with congenital heart disease, I think will be in large part mirrored in the pediatric space. There's really no reason to see it as distinctly different in this instance.
Great, thank you.
I would add to that, Rebecca, if you have a chance. So,
sure.
Remember, the vaccines there's guidance federally, like from CDC and other places, but they are a state-run program. So different states may define what conditions are allowed differently. So you really need to look at your own state. That being said, I know in a prior one, we've talked about congenital heart disease and the severity of it. And, adults, we've seen some stuff, but from a child standpoint, I just want to make sure that people are aware that there was the latest publication that came out last week from CDC, there's an MNWR, looking at characteristics of positive test results in kids. And they looked at underlying conditions, and the cardiovascular diseases was 0.7%, which is right around what the underlying prevalence of congenital heart disease is in the childhood population. So that was very nice to see that we're not, I think anecdotally, we can all say we haven't seen this huge influx of cases that we were scared we were going to see 9 months back. But it's good to see some of the data panning out that fortunately the congenital heart disease population has not been as affected by this as they are by some other viruses sometimes. Certainly, the severe ones and people with underlying lung conditions, whether it's primary or secondary to their cardiac disease, I think I put them in a different category. But most congenital heart disease patients are doing quite well, even if they get SARS-CoV-2. Thank
you so much. I'm going to switch gears from pediatrics to adults now. So Dr. Jacobsen, here we go. As an adult congenital cardiologist, what are you telling your patients about receiving a COVID-19 vaccine? Do you have any sweeping recommendations or contraindications for the community?
I think first to start with, similar to what Matt is saying, there's kind of this federal phase 1 and subcategories of that, and then 2 and 3. And then at the state level, there's a lot of variability in what the states are including in the phase 1 or phase 2. And I think this specifically comes into play when we're talking about the high risk medical conditions. So Colorado varies a little bit differently than what the federal level states for their phases. I think it's hard to group all adult congenital heart disease patients into a single category, saying everyone should definitely get it or everyone definitely should not. I think when it comes to adult congenital patients, you have to take kind of 3 main factors into play. First of all, what's their age? Second of all, what are their comorbidities, especially their adult comorbidities? And then what is the severity of their congenital heart disease? So I think, it's kind of a spectrum. Early on in the COVID pandemic, the adult congenital community kind of came up with recommendations even about advising our patients whether they should be staying home or going to work. And a lot of that fell in kind of a low, moderate, severe risk category. I would say for me, and I think a lot of recommendations, kind of the severe congenital heart disease in people who I definitely think fall in the higher medical risk category would be age if they're greater than 65. 2, if they have some of the comorbidities, obesity, diabetes, lung disease, COPD, and then if they're kind of in the severe congenital heart disease category. And to me, that includes univentricular physiology, especially those who have had Fontan, anyone with pulmonary arterial hypertension or Eisenmenger syndrome. if they have a systemic right ventricle, if they are cyanotic at baseline, meaning their saturations are less than 90. And then kind of based on some of the newer guidelines, patients with trisomy 21 probably move up into the higher risk category, and patients with DiGeorge syndrome are 22q.
Thank you. Another question we got probably 40 times from the adult population was asking if any common medications, blood thinners, aspirin, would increase their risk of side effects from the COVID vaccine.
Per my understanding, and anyone else can jump in if they have other thoughts, but based on the way that this vaccine works, the thought is that there shouldn't be a lot of interactions with medications. And if there were, that they probably wouldn't be that significant of an interaction. And Satoshi, you can tell me if I'm right or wrong here, but some patients that are immunocompromised, whether they're on chronic anti-inflammatory medications or steroids or other immunosuppressants, are still being advised to get the vaccine, but they might not have such a significant immune response as, say, people that aren't on those medications. But as far as, aspirin, Coumadin, even some of the cardiac medications we use, there hasn't been shown to be any interactions.
Right. It's nothing specific for the mRNA vaccine per se. With regards to the blood thinner, I think it's similar to the other intramuscular vaccines. You need to be careful about some procedures for the intramuscular vaccine. So sometimes called like a hematoma. So the CDC recommends to use like the smaller needles, like 23 G or smaller, and then you need to kind of place a little bit more than usually, like 2 minutes, press the injection sites. But other than that, there's no specific interactions or issues with the mRNA vaccine. So in terms of the efficacy and the safety of the mRNA vaccines in the immunocompromised patients are not studied during the phase 3 studies. But that being said, how mRNA vaccine works is that they don't use like a live vaccines or killed vaccines. So from the basic science standpoint, no biological like plausibilities of any concerns for potential infections due to this mRNA vaccine, because it's not live vaccine. So, but we don't know how effective the mRNA vaccine is in these populations. So the CDC recommends to have a discussions with your provider whether the benefit of the vaccines outweigh the risk, the potential risk of the mRNA vaccine.
Thank you. And I love that you said or noted the CDC recommendation there to discuss with your care team, because that's super important to us at Conquering CHD. We know we're providing resources and this town hall, but we really want this to be an information gathering session for our patients and families, where you take this to your care team and get specific guidance. So with that, I want to shift a little bit and speak with Dr. Subramanyan, who is our surgeon on the panel this evening. We received several questions regarding safety in patients that have prosthetic valves or other surgically implanted devices. What can you tell us about the vaccine for these patients?
Yeah, that's a good question. Again, like they said for the other conditions that we already discussed, there is no evidence to suggest that the vaccine or the response would be any different in people who have prosthetic valves, conduits, pacemakers, left ventricular assist devices, and so on and so forth. Again, like Satoshi said, these specific subgroups were not enrolled in large numbers in the phase 3 trial for us to say, oh, we have definitive data. But based on the science and how the mRNA vaccine works, we believe that there's absolutely no indication that the vaccine will either hurt or the immune response will either be different in patients who have prosthetic valves, LVADs, or pacemaker. And I'll also add by saying the question of the medications that follow. For example, if you have a prosthetic valve and you're on Coumadin, Dr. Jacobsen just addressed that as well. We don't believe there is any interaction there either. So again, the recommendation is to talk to your provider, but off the bat, we do not see any reason to look at it differently just because you have a cardiac implant.
That's great news for a lot of people, I'm sure. Can we take it one step further, Dr. Subramanyan, and ask you, is there any additional risk for patients who have had recent interventions, like whether it's open heart surgery or an interventional catheterization?
Yeah, that's a good question. This varies a little bit from center to center and practitioner to practitioner, particularly with respect to cardiopulmonary bypass. In general, if you've had an interventional catheterization or that kind of a procedure, it is unlikely that it will meaningfully affect the COVID vaccination process or developing immunity. Particularly with respect to blood transfusions and cardiopulmonary bypass, some centers believe that going on the cardiopulmonary bypass machine or receiving large volume transfusions may modulate the immune response. There are some centers I know that say 4 weeks before and after a cardiopulmonary bypass run, you should not receive live vaccination, for example. There isn't very strong evidence to support one way or the other. So I'm going to say, please take this on a case-by-case basis and discuss with your provider to make sure the kind of procedure, kind of intervention you've had to determine the timing of the vaccination. But in general, scientifically speaking, I don't have strong data to say, oh, after a cath, you should not get the vaccine for X number of days.
Great, thank you. I have one last question before we open it up to the audience for their the live Q&A portion. And this goes to everyone out on our panel. Can you share recommendations for CHD patients and their families as we continue on through this pandemic? Does mask wearing, hand washing, and social distancing, still matter? And what about as patients and family members start to get the vaccine? Do all of those things still matter? I have a feeling I know the answer, but I think I would like the patients and families to hear from you all.
So the answer is yes. So I think the most important message would be that so we can't give the vaccines to the kids yet. Like Matt said, below 16 or 18 for Moderna, we can't give the vaccines to the kids who has the CHD. So how we can protect them is that the family members or other people who live with your kids should get vaccinated against the COVID, because there are a lot of cases that the pediatric cases of the COVID is from the household infection. So if you get vaccinated and then if you protected yourself, then that might lead to the protections of your kids. We don't know yet whether this mRNA vaccine could prevent the viral shedding or could prevent the asymptomatic infection. That being said, there is the monkey studies on the Moderna vaccines that shows there's a significant reductions in the viral shedding, as well as significant reductions in inflammations in the monkeys who get the Moderna vaccines. So what that means is that animal studies suggest that these vaccines may work for the asymptomatic infection. So we are hopeful that we could shows that evidence of preventing these asymptomatic infections and shedding. So from that standpoint, I think it's strongly recommended to get the family members vaccinated against the COVID. So that's kind of my message. And then as the phase 3 study shows that there is a 5% chance of breakthrough infections among the vaccinated people. So you still have some risk for the COVID infections, even though you get the vaccine. So from that standpoint, I think please use all precautions, such as wearing the mask, hand washing, and then the social distancing to protect yourself and your families until we, stop this pandemic.
I agree 100%.
Yeah, I would echo all that. And I would just say, the healthcare providers, we're kind of in that first wave. And I think a lot of us here, we've been vaccinated, and we can tell you when we go to work, we are still wearing masks. We are still following all precautions. We are still doing social distancing in the hospital and with our families and out and about. So yes, it's still very important. There's many tools to fighting this pandemic. The vaccine is just one additional tool that we have, a very powerful tool, but one additional tool. And until we, we're over this, we can't, give up those other tools we have with the hand washing, the masks, and the social distancing.
Great, thank you guys so much. Here's my plug for everyone: keep those masks coming. Get some cute ones. So we have been getting some pretty interesting questions in the Q&A box, and I want to turn it over to Jennifer Weiner, who, like I said at the top of the show, is our adult CHD director, and she's also a patient with CHD. So she has been watching the questions and will now start the live Q&A.
Great, thank you. Yeah, we got a few in here already. One of the questions was if a patient is on the transplant list, should they still consider getting the vaccine, or is that something that would be not recommended?
I can take that. I would say that just because they're on transplant list, they should not be considered a contraindication to get COVID. We generally, let's talk about vaccinations in general for a second. When I see someone pre-transplant, I think that's the opportunity to catch up on all the vaccinations so they can get the immunity they can get. Right now, I do not see a contraindication to get the COVID vaccine if you're on a transplant list.
Okay, great, thank you. Another question is, do any of you have experience with CHD toddlers who've contracted COVID, and what has the experience been like of those patients?
I can answer that, having taken care of a few patients in that age group with COVID. None of them, this is going to be a small sample of those I take care of, or those of my colleagues in Cincinnati. We have not seen COVID positive CHD patients in the hospital, minus a very few examples. I can tell you that I have several families who I take care of in clinic right now, where mom and dad are fortunately well enough to be home, but feeling terribly sick, they tell me, and their children with remarkably complex congenital heart disease also tested positive, but have showed very little symptom at all related to this condition. And so the notion that kids remain relatively mild in comparison remains true, even in the case that I'm particularly thinking of, one of the most complex patients that I take care of.
Okay. There's another question here about anaphylaxis episodes. One person indicates that their child has had anaphylaxis issues, and they want to know if there's a greater chance to have a reaction with the vaccine if they already have a predisposition to allergic reactions.
So I'll take that question. So it depends on what allergies your kid has. So if he has an anaphylaxis to certain medications, specifically polyethylene glycol, which is one of the components of the COVID vaccine, then your kids shouldn't get the vaccines. That's contraindication. And then also, if he has allergic to polysulfate, which is another kind of similar polyethylene glycol that has cross reactions. So that's also the CDC recommends they should not get the vaccines if they have anaphylaxis to the polysulfate, which commonly used in like ointments and creams, stuff like that. So, but the CDC says that if kids has allergy to like a food, like an egg, or like environmental things, then they say that it's not contraindication, so they can still get the vaccines. If they have anaphylaxis or severe allergy to these allergens, then they should stay at the sites of the vaccine center, and then they should wait, like observe for 30 minutes after injection, just kind of to be safer side. So I think it depends on what allergies he has, I think, for that question.
Okay, thank you. The next question is asking if there is a contraindication for someone who is in valve failure to receive the COVID vaccine.
I can take that one, I guess. I would say that, valve failure or even severe myocardial dysfunction are actually, I would consider them to be in the more high risk medical condition category. So I would actually recommend that they do receive the COVID vaccine, and they would probably be, considered to get it a little bit sooner rather than waiting.
Thank you. Okay, there's a question here about future vaccines. It says, among the medical community, is there a feeling of whether the mRNA vaccines are superior to the upcoming vaccines like AstraZeneca and Johnson & Johnson that use more old school technology? Dr. Kamidani, that might be for you.
So first of all, that the technologies of AstraZeneca or Johnson & Johnson is a new technology. So they're using adenovirus vector vaccines. So that's a newer technology. And then we are learning how effective these vaccines are right now. The AstraZeneca shows their interim results of a phase 3, which is kind of variable, like it depends on some like error happens in terms of the dosing. So the efficacy is anywhere between like a 60% up to like a 90%. And then Johnson & Johnson, we don't know the efficacy yet, but the Dr. Fauci said that the result will be available pretty soon. The Emory is also involved in this study too, so I'm blinded, so I don't know the results yet. But so it's to be determined. But anywhere above like 70%, that's really great efficacy. And then each vaccine has their benefits, like a pros and cons. So for example, Johnson & Johnson, the only required dose is just one dose, which is a huge advantage of this Johnson & Johnson. And then these vector vaccines can be stored at the like a normal temperatures of refrigerator, which is a huge advantage compared to the mRNA vaccine. So I cannot say, I cannot compare right now without absolute data. I don't know that answer the question.
Thank you. There's a question too about side effects of the vaccines. There was a question about, could arrhythmias be a potential side effect for someone getting the vaccine? Is that something to be concerned about, especially if you already have existing arrhythmias?
So the arrhythmia, I think that one of phase 3 studies had the one like a serious adverse event of paroxysmal like ventricular arrhythmia. I think they said like it's a serious like adverse events, but we don't know the detail. It was not written on the paper, but I can't think of any biological possibilities between these mRNA vaccines and the specific arrhythmia. That might be triggered by just a fever or high fever or like other, like a systemic reactions. So I don't know the cardiology specialists think differently or not, but.
No, I don't think it's a contraindication, and I'm more concerned about heart and rhythm issues that you can have from having
Right.
COVID than I am from having the vaccine.
Okay, great. Thank you. Okay, another question here. Since parents and adults are being vaccinated, is there a way to protect children with CHD? Is there a way to advocate for this group of patients to be prioritized in getting a vaccine if they're not in a priority group otherwise?
I can share. I think it's a good point to make, and we often advocate for some of our youngest patients who can't receive the influenza vaccine, that it's a real reason for the family to receive it. And sometimes, there are families who have never historically had the seasonal influenza vaccine, and we say it's the best way to protect your unvaccinated, newborn with CHD. We have certainly, and many children's hospitals have been advocating exactly what is being shared here, that until we have the ability to effectively vaccinate these populations, which are going to fall in some criteria of risk that is going to be at least categorized different than the general population, though just to reiterate the points we made earlier, we are not seeing a tremendous sort of result of risk in our hospitalized patients or in the patients we care for. But nonetheless, they are certainly going to fall under this notion of higher risk, that it would make sense that the parents who take care of them may be offered vaccine at a time that's different than the general population who share their age. I think it's very hard to know. Again, children's hospitals are sharing that type of point of view with the various state departments of health. I think a lot of it will depend on the amount of vaccine available at that time. So when we get to a point where the general public and 35-year-olds are potentially being vaccinated, it'll depend on how much vaccine is available. And if there's enough for everybody, then it won't be necessary to sort of stress the point of, does your child have complex disease of one type or another? But if there isn't, then there will be reason to take that approach. And so certainly hospital systems are advocating that. Essentially every state department of health is working with both the adult hospital systems in your state, but certainly also the children's hospital programs looking for advice. And so use Conquering CHD to make that point and to advocate that point. It is not unreasonable, but again, I think so much will depend on the actual vaccine available. And hopefully AstraZeneca and Johnson & Johnson will prove effective, because I think that'll be the best way that we'll find to vaccinate the majority of our population quickly.
Thank you. There's a question here about the potential long-term effects. Is there any potential harm done to the heart or other organs should someone with CHD contract COVID?
I think you're hearing a lot of silence because we don't have great data on it. We don't know. I could say we're not seeing it, in the CHD population specifically. We never never say never. There was always the concerns with athletes and some others, and we're seeing less and less of what we had feared. Certainly some, and there are some cases in the news for sure, but not to the extent I think that we feared. A lot of the kids who had really severe heart involvement with MISC, which is not acute COVID, but same spectrum, and we know some kids get really, really sick from a heart standpoint. This is not general heart disease community, but just standard kids with really bad heart function. They get better really fast, really quick. And we've looked at a number of them in their 3 months out MRIs, and they're all looking really good. I'm very surprised in a very good way that kids' hearts just, I mean, they recover very well. It's great. So, you know, have we seen, you know, a lot of the congenital heart disease kids having damage to their heart? No. Are we looking for it? No, we're not screening all of them and asking them to come in if they've had COVID. We're not saying we need to check you out. But we're certainly, if someone mentions they have COVID, we, you know, or had COVID, we think, okay, let's just make sure everything's fine here. But fortunately, we have not seen a whole lot of long-standing heart damage from it yet. But the jury's still out on that. Remember, it feels like it's been forever that we've all been quarantining, but we are still very early in the history of this virus.
Okay. Thank you. Roni, this might be for you. Will CHD clinics be receiving and administering vaccines as they begin to roll them out for different people?
That's a great question. And as soon as I know, I will let you know. I can tell you in Colorado, we are not getting any information about when subspecialty clinics will have availability to give the vaccine. Currently, we are not giving it to anyone at university, the adult hospital, unless they're greater than 75. And no one at the Children's Hospital is currently receiving it as a patient. So at least in my state, we have not gotten a lot of information from that standpoint either.
Okay.
I would just say, but be on the lookout because these things change very quickly. I would have answered exactly like Roni 2 days ago, but then was in contact with the person who is the department head of pediatrics at Cincinnati Children's, who is now being asked to provide numbers to the State Department of how many people do we take care of that are over the age of 16, because they may just start distributing to us in the coming weeks. It's not finalized and it's unclear, but I think clearly the states are recognizing that it's hard to distribute vaccine and that right now some of the best systems at distributing vaccines are the hospital systems that have distributed it to its employees. And so they're, you know, looking to take advantage of that, as well as the fact that I think, you know, we would be a trusted center for hopefully the majority of our patients. So that's not to say that that's what we're going to be doing at Cincinnati Children's for sure, but it is a brand new conversation. So do be on the lookout, and probably your hospital system is developing some sort of website, or certainly your State Department is. And so if you haven't Googled your, you know, Georgia Department of Health or whatever else, do that, because they, you know, now have stood up these tremendous websites that are updated daily with, you know, new recommendations as they change.
Yeah, Georgia, we're in the same boat where the state health department's reaching out to us to look at kids over 16. And just to clarify, you know, vaccines will probably not be done, you know, they're not going to be done in clinics per se, just the hospital systems. You know, pediatricians will likely at some point when there's enough supply be administering vaccines because that's what they do. It's part of their bread and butter, but not necessarily your outpatient CHD clinic. But the hospital, you know, one challenge the pediatricians will have is the Pfizer vaccine requires very stringent storage standards that most pediatrician offices will not be able to meet, yet hospitals can. So that is the reason why, you know, this vaccine is, you know, the Pfizer one at least. Health departments are looking at ways to get that into the people that need it with appropriate storage so the vaccines, you know, aren't wasted. So stay tuned and check with your state.
Okay, thank you.
Can I just add one more thing? In addition to what they're saying, I think if you are being cared for by multiple providers, and depending on what state you're in, there is the ability to get on a wait list where they ask you specifically what your risk factors are, what your child's risk factors are. So I think that's different on a state level too, and how they're going to really prioritize these wait lists, I think still needs to be determined, but that is available in some states where you might be able to advocate for yourself a little bit better.
Okay. that looks like all of the questions that we had on the live chat over here. So thank you all for answering them. I had one question that I was surprised I didn't see. If one of you would be able to tell us a little bit more about the side effects that we can typically expect to see once we get the vaccine, just so people are prepared when they do eventually get to have it.
Yeah, I think I got the mRNA vaccines and I just finished the second dose, but I think the things you need to know is that these vaccines are very, very effective, like 95% effective. What that means is that also cause some like a local reactions or like a systemic reaction. So that's actually a good thing. Like that's what we wanna see, because we want your body to respond to the vaccine. So when you get the injection, then your body is actually making the antibody. So you may see some soreness, tenderness, and then the redness where you got the vaccine. And you may have some like low-grade fevers or fatigue, like a tiredness or headache. But the key point is this doesn't last that long. Like typically it will get better within like 2 days or 3 days. And then you can use like a Tylenol or ibuprofen if it's not contraindicated from other reasons. You can use it. It doesn't cause your immune system response. So I think so it's very effective vaccines, but also at the same time that cause some reaction. So those are the common things. But other than that, as you all probably all know, the anaphylaxis cases are reported, but the frequency is only like 11 cases per 1 million doses. So, and then the CDC reported that all vaccinated people who had anaphylaxis got recovered. So other than that, there's no major side effect observed at this point. And then the CDC is actively monitoring midterm and then long-term adverse events following this COVID vaccine. So you may see more data, and then they have a meeting next week. So they might provide more information about what they learned from this initial implementations of the COVID vaccine. So,
thank you.
Thank you all so much. Oh, thanks, Jenny. As we are closing in on the time for this episode, I really want to thank all of the physicians for taking time away from their families and their busy, clinical, chaotic lives that we are all living in now. So I appreciate your time and your expertise. And I just want to read the very last comment we got in the Q&A was from a person in the audience that said she wanted to thank you all to the panelists who have taken the time to answer our questions. It has been super helpful and gives a lot of hope moving forward in the days and weeks to come. So I echo her sentiments and thank you all very much. Excuse me. Before we sign off, I'd like to remind the audience of Conquering CHD's research survey that we're doing on COVID-19 and CHD. Patients and family members can complete the research survey through March 31st. And the full study details and a link to the survey can be found on our website at conqueringchd.org. Just a little tidbit of knowledge. As of last Monday, January 12th, we've had 335 patients complete the research survey, and 17 of those patients indicated they had a positive COVID-19 test. Of those 17 patients, only one person reported having to be hospitalized for their COVID. So I think that's excellent. And it just goes to show that what you guys are all saying, we're seeing in real life. So, and if you're new to Conquering CHD, please check us out on our website. We have a really great, robust library of educational materials for patients of all ages and your families, opportunities to connect with support groups on social media, which also features some really awesome weekly chats specifically for the ACHD patients that have been really, really popular. So as we continue our work towards conquering the most common birth defect, we hope to receive your feedback on today's events and see you for our next episode. So thank you all and have a great night.